And thanks again to Dr. McNeely for helping me out a lot, even as he was baking some quiche last night.
I can explain.
So the focus is going to be on the approach to imaging after first febrile UTI in infants, and some of the current ideas on the role of continuous antibiotic prophylaxis. I'll start with a bit of background, and then discuss our evolution of thinking about febrile UTIs, why we did things the way we did before, and why our thinking is starting to change. And as mentioned, the focus primarily will be on imaging and prophylaxis. So within the first 8 years of life, around 8% of girls and 2% of boys will get a urinary tract infection. Febrile urinary tract infections are most common in the first year of life. For boys, the incidence peaks in the first year at about 6 months, felt in large part due to the presence of the foreskin. And then from there on out, the girls take over, and they have more UTIs until BPH sets in and urinary retention becomes a problem. So the significance of fever, as it increases the likelihood of pyelonephritis, anatomic abnormalities, and the chances of renal scarring. So here's a look back at the evolution of our thinking about febrile UTIs. Starting in the 60s, there was data linking recurrent UTIs with renal scarring. The first study cited here showed about a third of kids with recurrent UTIs had subsequent parenchymal injury. And the second study showed significant long-term morbidity for children hospitalized with UTI, including persistence and recurrence of infection, renal failure, and death over a follow-up of a period of 27 years. It's a shot of Dr. McNeely in high school there. So the problem was that both studies assumed that kidney damage was related solely to urinary tract infection, overlooking the possibility that congenital renal abnormalities contributed to these outcomes. As better imaging techniques were developed in the 80s, more renal abnormalities were picked up in utero prior to any incidence of urinary tract infection. So in the 70s, there was a growing body of evidence linking vesicoureteric reflux to febrile urinary tract infections and subsequent scarring. Building on earlier results, a link was established to the long-term consequences of hypertension and chronic kidney disease. And at this time, studies by Ransley and Risden established the so-called Big Bang theory, which stated that it was the first febrile UTI that caused the most damage to developing kidneys. And in this era, surgical correction was the standard of care. So in the 80s, a lot of work was done in large part by a group of nephrologists led by Smelly in the UK, showing that surgery and antibiotic prophylaxis were equivalent in terms of scar. The surgery arm of one of these RCTs did show a benefit in reducing the recurrence of febrile UTIs, but in light of this data, there was a move away from performing surgery on everybody to performing surgery on some and using antibiotic prophylaxis in others. So this body of data led to the paradigm outlined here, namely that reflux predisposes to pyelo, and reflux plus infection causes scarring. So this was the basis for providing antibiotic prophylaxis to children who developed a febrile urinary tract infection. was felt that it was better to prevent UTIs than to wait to treat until a recurrence had occurred. This was outlined in a number of studies. You can see some listed here, publications from the New England Journal and the Journal of American Pediatrics as well. So in simple terms, the strategy was to identify refluxers and aggressively prevent recurrence. Initially, surgery was the standard of care, but following the work of Smelly and others, prophylaxis was thought to be equivalent to surgery for preventing scarring. So now researchers are beginning to ask the question, what is the significance exactly of reflux? And if reflux is not significant, what is the basis for using antibiotic prophylaxis? In addition, some have also started to question what the effects of prophylaxis are. So I want to shift our focus now on the approach to imaging, keeping in mind this shift in ideas about the significance of reflux. So I'll start by talking about the traditional bottom-up approach, somewhat newer top-down approach. I'll discuss the 2011 American Association of Pediatric Guidelines, as well as the guidelines from the National Institute of Health and Clinical Excellence from the UK, and then some of our own guidelines here from BC Children's. So the so-called bottom-up approach is based on the principles of the old paradigm I outlined earlier. The focus starts at the bladder, primarily to identify reflux. Here's a little schematic summarizing the bottom-up approach. Starts with renal ultrasound, and under the 1999 American Association of Pediatrics guidelines, children aged 2 to 24 months were recommended to have VCUG at the earliest convenience after treatment. If an abnormality such as reflux was detected, the child might go on to get further imaging, such as with a renal scan with DMSA. So what we ask is, reflux really significant? This is a table clipped from a review in the Journal of Pediatric Nephrology from 1998, comparing the rates of scar after acute pyelo in patients with and without vesicoureteric reflux. You can see highlighted here that scarring can occur both in the reflux and non-refluxers. So you can see that reflux is not essential for the presence of scarring. This RCT here from the Journal of Pediatrics, which we'll actually revisit a bit later when we talk about prophylaxis. We looked at kids 3 months to 18 years, randomly assigned to prophylaxis or not, following an episode of pyelo. As you can see, it showed that mild to moderate vesicoureteric reflux did not increase the incidence of UTI, pyelo, or scar over a 1-year follow-up period. Meta-analysis here, actually led by a radiologist in the UK from 2003, looked at VUR as a predictor of renal damage in children hospitalized with a urinary tract infection. It was a total of 12 studies and over 1,000 kidneys. Their conclusion is highlighted here in red, was that primary reflux is neither sufficient nor essential for the development of renal scar. So in light of this data, some have begun to advocate a different approach to imaging. So the so-called top-down approach, which places less emphasis on reflux, focuses instead on identifying scar. Here again is a schematic outlining this top-down approach. You can see it begins instead of with VCUG, but rather with a renal scan. If an abnormality is found, such as a cortical defect or hydro, further imaging such as a VCUG or ultrasound is performed.
Sorry, roughly what's the timing of that? After the UTI?
The different guidelines that some of the studies I'll get to mention some different thoughts on when the imaging should take place. For those less familiar with DMSA or dimercaptosuccinic acid, it's an agent chelated with radioactive technetium. Its primary advantage is that it's bound in the proximal tubule rather than being excreted, so you get some imaging of the cortex, which is advantageous when you're looking for parenchymal damage. It involves about 1 millisievert of radiation. That's the equivalent of about 50 chest x-rays. Looking at this slide here, you can see in the top panel, panel A, there's a focal area of photopenia, which would be suggestive of scar. In contrast to panel B on the bottom there, you can see global reduced uptake. That's something that might be seen in hypodysplastic kidney. So one of the main advantages touted by advocates of the top-down approach is that you can avoid the VCUG, which parents and children can find a little bit traumatic with the need for catheterization. There's also the issue of radiation. It's a little bit of a higher effective dose than for VCUG at about 1.6 millisieverts, and that's about the equivalent of 80 chest x-ray. And ultimately, and most importantly, if reflux doesn't matter as much as we thought, then why bother beginning with the VCUG to begin with? So getting to some of the evidence for this top-down approach. Here's an article from the Journal of Pediatrics in 2007. It's a prospective study, 290 consecutive kids in Sweden, less than a year old, presenting with a first febrile UTI. They all got a DMSA scan within 2 weeks and a VCUG within 2 months. And in their study, they reported identifying 96% of cases of high-grade reflux. And they concluded that in all they could have spared 140 unnecessary VCUG scans. Another prospective study here from 2009. 121 children involved with febrile UTI, and they'd had an initial abnormal DMSA scan. And in their study, they showed that it predicted the presence of clinically significant reflux, i.e. high-grade reflux, with an odds ratio of 4.2. So again, no cases of high-grade reflux were missed that initially had an abnormal DMSA scan. So the main disadvantages of the top-down approach, um, is that essentially you need to repeat the scan in 6 months or so to look for permanent scarring, which occurs in about 40% of those with an initially abnormal DMSA. There's also the minor concern of getting an IV, if that's worse than a catheter. And the advocates of the bottom-up approach would say that there are cases of high-grade VUR, even if it's a small number that you might be missing, and therefore you're missing cases of preventable renal damage. So getting to the guidelines. The American Association of Pediatrics just released new guidelines last year. They recommended that febrile infants with UTIs should have an ultrasound. They cite as benefits that you'll pick up abnormalities in about 15% of cases, 1 to 2% of which will require further action, such as surgery or some kind of additional workup with imaging. The main risks that they cite are a 2 to 3% false positive rate, which could potentially lead to unnecessary or invasive evaluations.
So what age are they calling?
They focus on age 2 months to 24. So this is in contrast to the 1999 AAP Guidelines. Here they're not recommending VCUG routinely after a first febrile UTI. VCUG is only recommended for those with an abnormality on ultrasound. So they go on to say that further evaluation, example with VCUG or DMSA, should be done if there's an occurrence of febrile UTI. But again, they state that the benefits of holding off on the VCUG are avoiding the radiation dose that we discussed earlier, the expense of the scans, and this discomfort that comes with having a Foley catheter placed. And again, noted as a potential risk of the possibility of missing cases of high-grade reflux, and thereby missing the opportunity to intervene and prevent renal damage. The approach advocated, the argument made by those advocating the bottom-up approach. I think this quote really sums up nicely their rationale for the new guidelines. If prophylaxis is in fact not beneficial and VUR is not required for the development of pyelo, then the rationale for performing VCUG routinely after an initial febrile UTI must be questioned. And we'll get to the evidence on prophylaxis in a bit. So these are the NICE guidelines. The National Institute for Health and Clinical Excellence in UK are a little bit older, from 2007. But again, they do not recommend routine VCUG after first febrile UTI. And this is coming from the UK, where in general their approach is a little bit more conservative than here in North America. So this is their table for imaging for kids 6 months to 3 years with a febrile UTI. So you can see that they recommend ultrasound routinely for what they're calling atypical urinary tract infections, and in their definition they talk about things like elevated creatinine, positive blood cultures, a child looking acutely ill, or the presence of unusual organisms. And again, ultrasound is also recommended for recurrent UTIs. But